You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for January 9th, 2026. Today, I'll talk about the limits of knowing your coronary artery anatomy, fish oil and atrial fibrillation risk, a new drug for PSVT, and maybe I was wrong about a drug for AFib conversion, the RAF4 trial. First, I say welcome back, everybody. Happy New Year. I hope you had a nice holiday. It's warm and rainy here in Kentucky, and as it goes in the winter here, we go from very warm days to bitter cold in a matter of hours. This week was nice, but next week we have proper winter. All right, first topic is the prediction of coronary disease is hard, even if you know the anatomy. On the last podcast of 2025, I covered a single-center study looking back at 465 patients who had had a first MI, and the authors sought out to determine how well risk scores would have predicted that event. The main take-home from their observations was that it was pretty hard. Most patients who had had an MI came from low-risk categories. The authors sort of called it the MI paradox, wherein these pooled cohort equations or risk scores fall short. They wrote something like, even though low-risk individuals have a small percentage chance of having an MI, there are so many more people in the low-risk category that they contribute a large absolute number of heart attacks. And as the authors note, that the large denominator of low-risk asymptomatic individuals means that even a small percentage of events in this group results in a considerable absolute number of MIs. Now, you would think that knowledge of coronary anatomy, such as the number of diseased vessels or the presence of non-calcified plaque, that would help in prediction of first MI, right? Yet, a study of more than 30,000 individuals from 6 hospitals in Sweden, all who had CCTA images, it also revealed the difficulty in predicting first coronary events. JAMA published a study, and the cohort of patients came from what's called the SCAPIS, or the Swedish Cardiopulmonary Bioimage Study. This is a general population-based prospective study, and it's designed to extensively characterize more than 30,000 individuals and obtain information that might be used to improve prevention strategies for cardiovascular disease. Now, for this particular study, the authors basically compared 2 groups. Those with no coronary event, and here the N is about 25,000, versus those with a first coronary event, and here the N is 304 patients. And again, all had CCTA images. The first metric the authors used in this comparison study was discrimination between those with and without an event, and using the C statistic, and that is a test that distinguishes between people who will have an event versus those who won't. The C statistic is like a report card where 0.5 is random guessing or flipping a coin, and 1.0 is perfect prediction. Well, the C statistic for the model using only the pooled cohort equation was 0.73, and it increased to 0.76 for the PCE in combination with coronary artery calcium, and then it increased to 0.78 for the pooled cohort equation in combination with the anatomic CCTA data. Now, these may be statistically significant, but to me, that is not much difference in clinical terms. What's more, when the authors broke down the C statistic for subgroups according to whether the PCE defined low, moderate, and high risk, there was improvement in discrimination with the CCTA was only positive for the low risk group, but not moderate or high risk. Okay, what about reclassification? The paper reports a net reclassification index, which is a fraught measure in my opinion. Here's what Claude says about NRI. The NRI is a statistical measure used to evaluate whether a new predictive model improves risk classification compared to an existing model by quantifying the proportion of individuals correctly reclassified into higher or lower risk categories. So you have a prediction model with PCE. That's simple. Just plug in the numbers. Now you add anatomy to it. Well, how does it reclassify? Basically, the NRI here of 13.3% sounds good. But NRI is sort of a simple sum of relative improvement in reclassification among those with events who had net correct upward reclassification over those without events who had net incorrect upward reclassification. The NRI belies the absolute number of people with events versus without events. Recall that my first description of this study, the two groups, revealed one group of non-event people were 25,000 N, and the other group had an N of 300. So for people with events, approximately 300, the CCTA data correctly reclassified up 44 people, which is 16%, and incorrectly reclassified down 4 people, 1.4%, and they get a net reclassification correct of about 14%. For people without events, that's more than 10,000 people, CCTA incorrectly reclassified up 236 patients, or 2.3%, and correctly reclassified down 66 people, or 0.6%, and the net correct here is negative 1.6%. So now, even though 14% plus a negative 1.6% ends up being an NRI that sounds good of around 12 to 13%, the absolute numbers reveal that when you look at the total people reclassified, it's not good. So correctly reclassified who had events, 44, incorrectly reclassified no events, 236. The total is about 200 people moved to a higher risk. But of these 200 people, only 44 or 16% were correctly reclassified, and 236 or 84% were incorrectly reclassified. So if you translate that roughly to clinical decisions, is that if you get a CCTA based on this data and you're moved to a higher risk category, perhaps because you have disease, you have about a 1 in 6 chance, 16%, that this is a correct upper reclassification, and a 5 in 6% chance, 84%, that this is incorrect. And so the authors conclude, and let me paraphrase and partially quote their first paragraph in the discussion section. They write, in a group without established CAD, we found that the addition of data from the CCTA to a model based on the PCE and a coronary calcium score improved discrimination modestly for coronary events during 8 years of follow-up. Then they go on to say that these results show that CCTA data have a value beyond risk factors and the coronary artery calcium score in identifying individuals at high risk of coronary events. But, however, they write, the observed absolute risk in the population was very low, and very few individuals had a risk level above the currently recommended threshold for preventive indication. Therefore, the clinical value of adding CCTA to improve risk prediction needs to be further evaluated in populations at higher risk and in parallel with a health economic evaluation. Now, everything they write is technically true, but I think it could be restated in a more sobering way. What I take from this data as a clinician, or even as a middle-aged person who could have an MI, is that CCTA improves the statistic by a meaningless amount. I mean, if a test on you has a C-stat of 0.73 or 0.78, that doesn't matter. It's meaningless. And as for reclassification with CCTA, if you find disease, you would think this helps reclassify. But it's wrong way more than it's correct, 5 out of 6 versus 1 out of 6. And the authors do consider the downsides of CCTA. The radiation is one, the potential risk of contrast injection, and of course the downstream overtreatment from revascularization of stable disease. I would also add that perhaps the Swedish environment where this is done makes it harder for CCTA to do anything predictive. That is, in this study of 8 years, only 1.2% of people had an event. But still, incorrect reclassification occurs in 1.6% of 10,000 people, and it's a much bigger number versus correct reclassification in 14.2% of 300 people. So But I doubt, even if the event rate was higher, say 3% or 5%, I doubt CCTA would still make a difference. And you think, well, maybe I'm a total Luddite when it comes to prediction and anatomy. I think we know how to prevent an MI already. We tell patients not to smoke, to eat well, exercise. And if a simple pulled cord equation predicts high risk and you want to avoid an event and do everything possible to avoid an event, you can take a statin. But this study and other studies really make me negative on the ability of getting a scan and knowing anatomy to really help prediction that much or to change future outcomes. Now, adding the scans may not help patients, but it surely helps those who make the machines and bill for the data, as well as the doctors and the hospitals who do all the follow-up testing. All right, next topic is fish oil and AFib. And as a bonus here, we learn again about the matter of analytic flexibility. So, medicine is full of mysteries, and one is that the recent RCTs of fish oil used as cardiovascular risk reducers found, surprisingly, an increase in the risk of AFib. I mean, they weren't looking for AFib. They were looking to see whether fish oil reduces cardiovascular outcomes. But they found this signal of AFib. In a meta-analysis of RCTs, the first author is Gia, found a clear increase in AF risk when you consider the trials. Most notably, it was a graded association based on dose. So higher dose of fish oil, more AFib. Now, adding to the causation story is yet another trial that wasn't covered in this meta-analysis called the ReSPECT-EPA. This was a Japanese RCT of EPA, that is 1,800 milligrams of icosapent ethyl administered daily versus control, no placebo pill, just control, in about 4,000 patients at 95 sites in Japan. ReSPECT-EPA found a 21% reduction in a MACE endpoint, but it barely missed statistical significance. But new onset AF was significantly higher in the EPA group, 3.1 versus 1.6%, and that was statistically significant. Now, adding further to the strength of this observation that fish oil can cause AFib is an observational analysis of the UK Biobank published in the European Journal of Preventive Cardiology back in 2022. First author here is Zhang, and I'll cite all these papers, which did find that reported fish oil use was associated with a 10% higher AFib risk that met statistical significance. But now, last month, the Journal of the American Heart Association has published a provocative observational study from the same UK Biobank correlating omega-3 levels and reported fish oil supplement use with AF risk in a very large sample of adults in the UK. This study was very similar and used very similar individuals from the UK Biobank as the one I just told you in the European Journal of Preventive Cardiology. I mean, it's a huge trial, sample of 260,000 individuals and 466,000 individuals who reported fish oil supplement use. Before I tell you the results of this new UK Biobank study, we should say that you'd want observational data to support the increased risk seen in the RCTs. If fish oil is causative in AFib and we see a signal in RCTs, we should also want to see the signal in the observational data. And we did with that European Journal of Preventive Cardiology study. But this is actually not what these Kansas City research team found in the more recent observational study. In their UK Biobank sample, omega-3 levels were inversely associated with AFib risk, and this relationship was statistically significant. And the second aspect of this study was after adjustment, they found no increase in AFib risk with fish oil supplementation or reported fish oil supplementation use. And you might be asking me, you just told me that a UK Biobank observational study found a positive association with fish oil supplement use, but a different group of researchers found no association. So what gives? Well, what gives is the crucially important issue of analytic flexibility. Namely, that in this more recent Kansas City study of the UK Biobank, the authors adjusted for age as a continuous variable, while the earlier study, the Zhang et al. Study, adjusted for age as a dichotomous variable. Kansas City authors argue in the Journal of the American Heart Association that their adjustment technique is better. But I, and likely you, have no idea about adjustment techniques in observational research. The point, though, is that if association data is this flexible, it tells me that it's pretty weak evidence. Therefore, I continue to weigh the RCT observations that fish oil supplementations increase AF risk more strongly. Now, you might not agree. Your comeback might be, John, how do you explain this mechanistically? How does a fish pill increase AFib risk? My answer is that I don't know, but it doesn't matter. If enough randomized comparisons show the same thing, I think we have causal evidence. For example, we accept that SGLT2 inhibitors improve outcomes in some patients, but we aren't sure how the drug works. Now, the final argument against my RCT-bolstered belief that fish oil increases AFib risk comes from one of the strongest thinkers in all of cardiology, Professor Stanley Natel, who wrote with Dr. Michelle Samuel that the RCT findings may be biased because most of the trials did not adjust for the competing risk of death. I'm going to link to their argument, but basically, they observed that in most fish oil RCTs, the risk of death is many times greater than the risk of AFib. And if fish oil had even a modest effect on lowering the rate of death, the finding of increased AFib may be biased by not controlling for the competing cause of death. Now, my problem with that argument is that none of the fish oil trials were powered to assess the risk of death. They all had multi-component MACE endpoints, and I find it unlikely that fish oil substantially affects all-cause mortality. And if that is true, I find it unlikely that adjusting for the competing cause of death would eliminate the signal of increased AF risk with fish oil. Now, in summary, I don't doubt that observational studies of reported fish oil use or omega-3 levels could identify a group of people who do other things to avoid AFib. I mean, the RCTs have a clear signal of increased AF risk. There is a dose-dependent response. And I don't think there is any substantial cardiovascular benefit to the fish pills based on the negative trials and the problems with the positive trials, for instance, the bad control group in the Reduce It trial. So in the clinic, I tell people who come to me for help with their AFib to eat fish, not fish pills. It may not help to reduce the fish oil intake, but there seems little cost in stopping these supplements to see what happens. All right, third topic today is a new drug for SVT. While we were on holiday, the FDA approved a drug called etripamil, which rhymes with verapamil, and is, get this, a nasal spray to stop SVT. It's a rapid-acting calcium channel blocker like verapamil, but it goes up the nose instead of via a pill. The supporting RCT was called the RAPID trial and was published in The Lancet back in 2023. SVT conversion rates in the trial by 30 minutes were 64% with etripamil, 31% with placebo. That was a hazard of 2.62 better with the drug. The median time to conversion was 17 minutes with the etripamil regimen versus 53 minutes with placebo. There were some local side effects in the nose, but no major adverse effects. The drug will be called Cardamist. I'm not sure how popular it will be, though I think it may have a role depending on how expensive it is. Now, let me just take a minute to opine on SVT treatment, and I don't think I have, or it's been a long time. I think there's a temptation in some of my colleagues to just say SVT is curable. Patients should just have an ablation and be done with it. But I think this is a bad take. The older I get, the more nervous I am ablating SVT. Why? Because these are often young people, and because most of the time SVT is AV nodal reentrant tachycardia, or AVNRT, which is usually easy to ablate, but occasionally it's harrowing due to the close proximity to the AV node and the variable anatomy of the AV node. And a mistake in this area can cause AV block, and you can make your patient lifelong dependent on a pacemaker. And yes, I know people will say, if you are careful and experienced and perfect, you should be able to avoid iatrogenic AV block. But I will tell you that this is a black swan event, and I will tell you that everybody is human. And although this complication is rare, Or super rare, it's catastrophic when it occurs. It's like a black swan event. So my approach, the Mandrola approach to typical patients with SVT, I'm not talking about policemen or firefighters or pilots or patients with heart failure or patients with syncope. I'm talking about the standard patient with SVT who has rapid tachycardia, comes to the ER, sometimes requires adenosine. So my first approach is to reassure patients that while SVT is bothersome, it is benign, and it almost never causes cardiac arrest. So you remove fear. Then we go over ways to break the tachycardia. For instance, lowering sympathetic stimulation, then doing vagal maneuvers. In that order, the initial lowering of sympathetic levels by sitting or lying down is crucial because vagal maneuvers are unlikely to work when people have a sympathetic tone of 11 out of 10. Now, some patients who have SVT may have hypertension, and they have another reason to take medicines. And for these patients, you can treat the SVT with a beta blocker or calcium blocker, and you can treat hypertension and SVT at the same time. Though I will tell you that I think daily medicines for SVT is a very inelegant solution because you're giving somebody a daily pill for a problem that may occur one time every 6 months. It's the same actually with paroxysmal AFib. I find AFib medicines very inelegant for people who have fairly infrequent episodes of AFib. And the third aspect of SVT treatment discussion is to discuss ablation. And while it is true that most often this is an amazing procedure, it's easy, highly curative, there are those small but finite risks. So ultimately, the treatment of patients with PSVT, I think, is one of the best examples in all of medicine of a preference-sensitive decision. I emphasize this strongly, and I use those words every time I see a patient with PSVT. Indeed, ablation is great, but what a patient chooses is ultimately up to them. And that is where a drug like etripamil comes in. For some patients with infrequent episodes of SVT, taking a sniff on a nasal inhaler once in a while may be preferable to having an invasive procedure. All right, another topic, AFib conversion with a drug called Vernakalant. Well, speaking of drugs for conversion of rapid new onset tachycardia, the BMJ has published the RAF4, that's RAFF4 trial of Vernakalant versus procainamide for the acute conversion of AFib. Now, for my U.S. colleagues, you likely have never heard of the drug Vernakalant, which is an atrial-selective antiarrhythmic that works primarily by blocking multiple ion channels with particular effects on atrial tissue. Namely, it blocks atrial-specific potassium channels, especially Kv1.5, which carries the ultra-rapid delayed rectifier current, IKUR. And it also inhibits sodium channels in a frequency-dependent manner, prolonging atrial refractoriness and slowing conduction to terminate AFib while having minimal effects on ventricular tissue. Now, U.S. colleagues have never heard of this drug because the FDA rejected it. And I was on the AdCom committee that recommended against it on its second review in 2019. The main problem was that A, there are plenty of ways to convert AFib in the emergency department, and B, there were some major safety concerns. Now, while I am a strong advocate for the give peace a chance approach to acute AFib, and I believe that my emergency medicine and cardiology colleagues are way too quick to shock people with AFib, I do recognize the advantage of quickly getting someone out of AFib because having AFib is a buzzkill. But I hate shocking people. I really do. Even now, after thousands of cardioversions, I find shocking people for AFib very displeasing. It's aggressive, it's ugly, I don't like it. What's more, if you wait, many of these patients will convert to sinus rhythm on their own. But if there was a drug that was safe and easy, I can see the benefit. In fact, I use procainamide to convert AFib fairly often, especially, for instance, in the EP lab when AFib makes SVT ablation impossible. You have to do something to get rid of the AFib. So RAF4 was a multi-center Canadian trial. There were 350 patients that were randomized. These patients had new onset AFib. It was simple, procainamide versus Vernakalant, and the primary endpoint was conversion to sinus rhythm, and Vernakalant won. It was more effective. 62% versus 48%. That's an adjusted absolute difference of 15%, and it was highly statistically significant. And the time to conversion was faster with Vernakalant, 21 versus 44 minutes. Fewer patients in the Vernakalant arm had electrical cardioversion, and adverse events were similar in both groups. These were generally mild and brief, and most patients were discharged home. So there were no terrible events. And the subgroup analysis strongly favored Vernakalant for the conversion of patients younger than 70 years of age. This was a heterogeneous treatment effect noted. So my comments. I don't know. I remember that AdCom committee meeting. There were very strong and influential people on it. I may have been swayed by those leaders. I had never been on an AdCom committee meeting before. RAV4 trial was clearly positive for Vernakalant. It was clearly better than procainamide. It's far easier to give than procainamide. Vernakalant is given in a 10-minute infusion versus a 60-minute slow infusion of procainamide, which then hangs around for hours. So Vernakalant is approved for use in Europe and Canada, and I'm not sure how often it is used. But this trial seems highly supportive of the drug. I'd be open to relooking at this because acute conversion with a well-tolerated drug in the emergency department would be kind of nice. My colleague and friend Rita Redberg co-wrote an accompanying editorial in the BMJ, and they stand with our initial AdCom meeting against Vernakalant. They cite two things, really: alternatives for cardioversion and the fact that a 350-patient RCT cannot allay safety concerns. And I think these are all good points, but there are actually some counter-arguments. Let me first address the issue of having alternatives for cardioversions. The alternatives that we have for cardioversion in the ER right now are not great. They're not totally safe. Ibutylide, for instance, has a 2 to 3% risk of torsade de pointe, which is way worse than AFib. And also, you could say cardioversion with a shock is an alternative, but this requires heavy sedation. And I have seen serious post-shock rhythm disasters. And of course, there is amiodarone and its potential safety issues such as hypotension. So while Vernakalant has had some safety concerns, I think perhaps it's best to consider safety of a new drug relative to the existing alternatives, which are not free of adverse effects. Well, maybe here some your listeners could weigh in. I feel like maybe FDA was too strict on this one. Okay, I was going to make a note on HFpEF. There's a nice editorial in Jack Case Reports, but I've already gone on for long enough, and I'll leave that for next week. So this is it for This Week in Cardiology. As always, I'm grateful that you listened. Thank you. And if you like this podcast, please take the time, give us a rating, write me a review. If you disagree with something I say, please send me a note. I'm going to make a new folder in my email program for listener feedback so that if you send me a note on a Saturday, I won't forget about it the next Friday. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.